Welcome to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. With me today is my friend, Dr. Andre Campbell. Dr. Campbell is professor of surgery at the University of California, San Francisco School of Medicine, where he also serves as vice chair of diversity, equity, and inclusion, and is an attending surgeon at the Zuckerberg San Francisco General Hospital. Dr. Campbell, of course, also is our secretary for the ACS Board of Governors. Welcome, Andre.
Thank you so much. And it's a pleasure to be here with you, Stephen. It's really outstanding program you have with bulletin briefs and the videos that you've been collecting. So it's my honor to be here to chat with you today. This is a big part of my life. I've taken my whole life taking care of trauma patients, caring for the injured, touring the world, and also learning as much as I can about caring for trauma patients, working with the VRC and the Committee on Trauma.
Well, thanks so much. And you're involved in so many different things, from the diversity, equity, inclusion, and trauma, the Board of Governors, social media, running your fellowship program. There's a lot of subjects about which we could talk, but perhaps we could focus on what has happened to trauma care during the era of COVID-19.
What we noticed with COVID and trauma. So what happened? So when COVID came, what happens is the numbers of incidents of trauma went down significantly because people were staying at home. But slowly but surely, as we open things up, more things happen. But the truth be told, that over time, what we found is that the incidence of certain type of injuries started going up. If you keep people at home and they're in an environment where things may not be so good, there's instances of more interpersonal violence between groups of people who are at home. That actually went up. And also what we found in big cities like San Francisco, New York, Philadelphia, Chicago, and other places, that the incidence of penetrating trauma has actually gone up. I mean, the other night we had 9 victims who were shot. We haven't had anything like that in, I think, 5 years, 10 years. It's been a long time. So the incidence of these things are going up. And that's not just San Francisco, where I live, it's all over the country. So this is sort of something that we notice. So the patterns have been changing. And this may be related to interactions and socioeconomic interactions in the community related to some criminal elements or other things, but this is sort of something that we've all have noticed, and it has had a big impact on our patients there. So that is how COVID has affected us. Not only revealed that the types of injuries have changed, but also it's revealed the disparities that have happened related to COVID and its outcome.
Before we get to disparities, trauma is something that is the antithesis of what I do in terms of elective surgery. So from the period of, I suppose, was maybe the second week in April until the second week in May or thereabouts, I wasn't scheduling elective surgery because we were concerned there might not be beds in the intensive care unit and or people to staff them and or PP back in those days throughout the world, not just me. In your practice, you don't have that choice. People show up, and as you say, maybe more people because more penetrating trauma and people are cooped up together inside of an environment where they're normally not together for 24 hours a day, weeks on end. Did you have any problem, either at your place or elsewhere that you're aware of, with ICU beds because they were so preoccupied with COVID patients that you couldn't really manage your trauma patients?
So in our place, what was done, and like many other places, is the amount of elective surgery went down significantly. So we went from what would be 10 rooms down to 4 or 5 rooms, both in the spring and more recently when we had our second larger surge, because we had to make sure we had enough room in the ICU because we were doing emergencies. So acute care surgery comes in, the perforations, people with appendicitis, people with gallbladder disease, those kind of things still keep coming in and we have to do them. But the things that we will be doing more electively, the hernias, the abdominal wall reconstructions, the colectomies, unless they had a cancer, if they had a cancer, then we would go forward and do them. And we basically made a tiered system, 1, 2, and 3. 3 people had to go within a week or a couple of weeks. Tier 2 is less urgent and tier 1 is less urgent. So by doing that, we were able to kind of get through things and make sure there's enough resources to do that. So in the first wave, we had about 45 COVIDs in our hospital. The second wave, we had about 70. And during that time period, we had about 10 or 15 in the ICU. So we had to make adjustments in how things are going. Now, the hospitals that do more elective surgery, it's a little bit different, but what we've been trying to do is making sure that we have enough room so we can take care of folks. There were some concerns initially with personal protective equipment not being enough. And, I walk in a room and I just assume now that everybody has COVID, like I did when it first happened in March. And so I wear 2 masks and a face shield, and I try to protect myself. And that's the best way to make sure you don't get sick. With doing it, the social distance, the masking, washing your hands, all these things that we all do to do that. But and now we're vaccinated. But the vaccine is not, I think, going to change our world anytime soon, because we're still going to assume that with that. But when I have a trauma patient, I was on call Friday night. Somebody comes in, I assume this is a COVID positive intubation, and I basically walk in there with maximum personal protective equipment on to make sure protect me and I protect everybody there. But more than that, I make sure that everybody in the room is protected, because we don't want any one of our healthcare workers, over 1,000 healthcare workers, up to 2,000 have died from COVID because they've been exposed. So this is a real serious pandemic. I mean, we just crossed north of 500,000 people who died yesterday. So it's been just a tragic, tragic thing for the whole country, and certainly affected us as surgeons also because of the way we practice and what we do.
Well, I think that's indeed very wise. Universal precautions, much as we did back when I was a resident in the early 80s, I suppose, mid 80s, when AIDS came out, and we just assumed everybody was positive and adopted universal precautions, which have lasted to this day. Universal precautions, kind of the same thing or somewhat analogous, having universal precautions. But the fact that as captain of the ship, you want to make sure your team is protected is both commendable and exemplary. One of the things you mentioned also about taking a toll on people, we've read and been told in many different forums that the toll taken varies upon one's ability to withstand it, shall we say, highlighting very unfortunate disparities in our healthcare system, whereas some people are less apt to perhaps get the care that they should. And maybe you can talk about how healthcare disparities have been even further uncovered by COVID-19, whether in trauma patients or otherwise.
So let me start off by saying is that we have known for over 2 decades that there are disparities in outcome, whether or not it's in your area, colon cancer, lung cancer, breast cancer, vascular surgery, trauma surgery in my area. We've known that there's been difference in outcome that occurs when you are injured in patients that I care for. When you look at big series, this is something that has been published and is well known. And the thing I just want to say, first of all, is that we have a little bit of problem in surgery that surgeons, there's been studies saying that 2/3 of surgeons do not believe that disparities exist. So the first thing I want to say is disparities exist in the care of our patients, and we need to be mindful, and we need to change the way we are caring for patients to make sure they get the best care possible. Now, I'm sure that everybody tries to do that, but maybe because of pre-existing conditions, social determinant of health, structural violence, these things are get in the way of what we can do when people come in and get our care. So here comes COVID. COVID then exposes again that there is disparity. So the amount that African Americans and Latino patients get admitted to the hospital is 2 to 3 times. The death rate is 2 to 3 times that of our white patients. And also Native Americans, similar data. So rate of hospitalization is higher, rate of death is higher. And then here we come afterwards with the vaccine. We would think that the vaccine would be given out equitably, but in the first batch of vaccines, 60% of people who received the vaccine were white, but 5% were Black. So again, the disparities that we had that we knew about for a long time, that we saw in many diseases are now coming there, so that we have to be proactive. And I had the pleasure of doing a piece with our Vice President, Dr. Elisa Newman. We're looking at how surgeons can advocate for vaccination. So we need to make sure that we get the word out in our community that it's safe. We need to role model. And I did the same thing on social media. I said, I took it, I'm safe, nothing happened to me. And we need to make sure that we deal with the issues of people being concerned. Well, maybe I've not been treated fairly by the healthcare system. Maybe I should wait. So we need to make sure that we encourage people. We do. I have a scrub nurse that I talked about the vaccine with, and he said, because of you and what you did, Dr. Campbell, I went to get a vaccine. And he then spread that around his family. So that again, we knew about it. It showed itself with COVID. And again, it shows itself with the vaccine. So we need to be mindful. We need to make sure that we understand that disparities exist. And we need to make sure we operationalize things like going to communities that may be affected because of social determinants of health, which include where you live, what you eat, your education, where you work, what your healthcare status is, all these things. Let's say if you don't have a car, you need to have the vaccine distribution place in a place where people can walk into. To do that, we need to go out and we need to make sure we meet these things head on and we make it much more equitable. So we have healthcare equitable, healthcare equitability for our patients who are affected, by COVID or by cancer, making sure that not the screening that goes on. I know that in your practice, I'm sure there's been less screenings that have happened. And because of that, our patients are coming in later with later disease processes, regardless of who they are. So we need to make sure that we continue to do the things we do to be mindful as surgeons for our patients.
No, those are all excellent points for sure. Many of those issues need to be dealt with on a systemic level by us as a society, or by our institutions and the like. On a personal, individual level, are there any particular caveats for people to help just in the instant case?
So on a personal level, I think the first thing we have to do, everything really depends on where you practice, right? And I think, you have to make sure that, I think as surgeons, we've always been patient advocates, and we need to just redouble our efforts to make sure that, well, maybe that patient, I work at a county hospital, so sometimes it's difficult for me to make sure that my patients get the best care possible. But I always make sure I go out of my way, particularly if somebody, let's say if they got a problem and they're homeless or they have no access to care, I make sure that we try to reach out, we try to get them care when they're post-op, we make sure they get a place to go so they can have adequate home care afterwards, get placement. So, pre-op, we try to make sure they're evaluated. So they're on a personal level, which can, depending on your practice. My practice happens to be in a place where I take care of inner city patients who are not so fortunate, but I've been able to make sure that by being an advocate, and that's, again, it goes back to advocacy, and that's what we are as surgeons. We are advocates for high quality care for our patients to make sure they get the best care possible. And if we take that mantra of advocacy of care to the personal level, not only for issues, legal issues, or things in Capitol Hill or State House, we have to advocate individually for that patient who may not be able to have all the things that other people have. And we got to make sure we get the care that they need to the place that we can reach them where they're at, to make sure they get the best care possible.
Excellent points. Absolutely. Advocacy is key. Advocating as a society and advocating on an individual basis, and recognizing people might have underlying conditions that haven't been addressed and need to be addressed while they're there, thinking beyond what we're doing for their colon cancer or their breast cancer, whatever happens to be, or their trauma, and taking care of the entire patient. Any other comments? I've enjoyed speaking to you, as I always do. Any additional comments that you'd like to share before we close today?
I'll just say just a couple of things. It's been absolute honor to be able to work within the College of Surgeons over 2+ decades, and many in providing service. It's just been an absolute honor. The American College of Surgeons has changed, and I think changing for better, which is great. I mean, having a show like this to get information out. The COVID crisis has really changed the college into a rapid reaction force where we are able to serve our members better. And I have to just say that I've been quite impressed, whether or not it's the Board of Governors, which I've been a pleasure to serve at for a number of years, or working now with the Board of Regents on the Executive Committee. It's been amazing, the things that I've seen happen, the advocacy, the new thing that's happened with the posture for anti-racism, and the document which is coming out on the leadership of Dr. Timothy Eberlein, who's one of the regents. I've been very impressed. So it's the College of Surgeons is there for us as surgeons, and it's been an absolute privilege and a wonderful thing for me to have a chance to work with the College of Surgeons over these last 2+ decades as a fellow of the college. Thank you so much for having me today.
My pleasure. It's great speaking with you today, and we're very fortunate to have your enthusiasm and your insights working on behalf of all of our fellows, and in fact, therefore, on behalf of all of our patients, serving with skill and fidelity for all, as you mentioned during one of your replies. So for now, I'll wish you sustained good health and look forward to seeing you in person one of these days, as opposed to on a screen, as we often do at our various meetings.
Yes, I would love to see you in person, Stephen. Thank you so much again. I appreciate it.